Welcome back to Health Law Pulse, the podcast where we talk about how healthcare, leadership, and law intersect in the real world. I'm your host, Jonathan Rhodes, healthcare attorney and founder of Health Law Counsel, LLC. Today, I'm joined by Aubrey Grabow, a healthcare executive and clinician whose career spans frontline patient care, clinical education, and senior operational leadership in large, complex healthcare organizations. Aubrey is a board-certified physician assistant and currently serves in a leadership role overseeing advanced practice providers, clinical operations, and quality initiatives. Over the course of her career, she has led large provider groups, helped design and implement value-based incentive programs, overseen delegation and scope of practice frameworks, and played a key role in building systems that support quality, safety, and operational effectiveness at scale. Aubrey's perspective is important because she's worked at the intersection of clinical care, operations, and compliance, where many of the most important decisions in healthcare are actually made, and where things tend to get complicated. In this episode, we talk about leadership transitions, scaling healthcare organizations, managing operational and compliance risk, the evolving role of advanced practice providers, and what strong organizations do differently when it comes to training, governance, and culture. This is Health Law Pulse. Aubrey Grabow, thank you for joining me today, the one and only, the great Aubrey Grabow. Appreciate you taking some time out of your very busy schedule to join us here on Health Law Pulse.
Thank you for having me. I'm excited to be here.
Well, we're very excited. So I like to start all these episodes off with just learning a little bit about what got you into your current medical practice, what got you into medicine, what kind of drove you. I know you've had sort of a transition from practicing to leadership. What if you take us a little bit through that journey and what drove you through to where you are now?
Yeah, sure. So I'm a physician assistant by trade, practiced about 19 years, mostly in family medicine. And the bulk of that was 16 years at the same place. So I grew up in Illinois at a multidisciplinary specialty practice and kind of got my legs there in leadership, APP leadership, clinical operations, learned a lot about metrics and quality. I had a leader who saw something in me while I was there and would kind of throw me side projects here and there, especially when quality and value-based care was just in its infancy and we were trying to move the needle on how do we take better care of our patients in totality, not just see a patient and they leave, see a patient and they leave, but how are we actually taking care of the whole patient? So dip my toe into that. Again, moved through 16 years of different projects and things. During that time is when COVID hit. Right. So went down and helped operationalize a hospital in the city. And that was where it sparked, hey, I think I'm ready to do more. I was working with, all the Chicago city EMS and fire and operations leaders and clinical leaders from everywhere around trying to support all of these COVID patients, and felt a pull like there's more that I can do. There's more that I can offer, learning how to set things up fast in an emergent situation, but also safely, but also support the patient again, more holistically, not just in clinical care, but there were all these other ways I could support. So when I went back to clinical practice, got lucky. I had a leader again, reach out that there was, a full leadership position with a large organization to start setting up healthcare systems across the country. Mm-hmm. And just felt like I needed a new mission in my life. I needed to be able to support patients much more globally. And so stepped away from clinical practice, which is not easy to do, especially when you've been doing it for 20 years, almost 20 years. And that's where I started my really 100% in leadership and operational and strategy and things of that nature. So that took me a couple years with that system where I oversaw operations of all kinds, clinical, education, APP leadership, really got to stretch my wings in a variety of ways very quickly. And when that sunsetted, I moved into my current role, which is APP director for a very large multidisciplinary system in the nation. So that is where I am now.
Excellent. Well, thank you for sharing that. And I sort of want to start there. It's a great segue from your journey to some of the learnings that I'm sure you have throughout that journey. One thing I've learned as a healthcare lawyer is that leaders who've actually taken care of patients, such as yourself, tend to have a much higher tolerance for reality, probably a much lower tolerance for for policies that look great in a board deck, but then fall apart kind of like today on a Friday afternoon. And
and as a lawyer, I'll admit, anytime I hear someone say, "Hey, that's a clinical issue, not a legal issue or a compliance issue," I know I'm about probably not always, but about to get very busy. And you built a career on that spans, as you mentioned, from frontline care, education, senior executive leadership. What motivated your transition from clinical practice, and you mentioned this a little bit, to more operational strategic roles? How do you feel that your background and your training as a physician assistant shape the way you make executive decisions differently than perhaps leaders without that clinical training?
So the first part, I think, I think COVID changed everything for everyone, I think, but that part of my career, when I stepped away from true clinical care into that operational role at the hospital, it gave me this bigger view on how do we take care of a patient in totality, right? How do we take care of their social economic needs? How do we take care of their clinical needs? How do we take care of their family needs? How do we, even down to transportation, insurance, how do you get their medications? All of those things. And I felt like I was making such a big difference in that time because I could touch all of these different parts and work with all of these different people that had this knowledge. They came from all different spaces, right? We had legal, we had compliance, we had police, we had fire, we had tech, but everyone was able to come together and work as a team to standardize the care we needed to provide the patients. And then I had the clinical knowledge, but also clinical operational knowledge to be able to help provide them with, this is how this works clinically and this is how we need to go this way from an operational perspective. That when I left there and went back to clinical care, it felt like I was missing something. It felt like every time I went to care for a patient, I wasn't doing enough. I couldn't take that next step. I felt like I was leaving something on the table. So part eh, part of that journey, over that course of that next year, my son was diagnosed with type 1 diabetes, and that took me personally into a journey of, how does my son get care
Mm.
and insurance and his medicines, and what does he need socioeconomically from a school standpoint, and how do I take all of this that I've learned and then make it big, right? And make it so I can take care of all of these other people. So that's what led me into the journey of stepping away from clinical care. And I think the personalization of what I went through, but also being able to work with all of those different teams, helped me in my next role, because it had to be a team during COVID, right? No, there was no one person that knew it all. So when I went to go build in the next organization, again, I had all this clinical knowledge, I had personal experience, I had some operational knowledge, but I knew I didn't have it all. And I think that was where I was able to say, okay, here's what we need and here's what I see, but what is it that I don't know and who do I need to help fill those gaps? And I think as a PA, one of the most important things you learn is, it is more important to know what you don't know
Mm.
than what you do know, because we aren't physicians, we are advanced practice providers, we are very well clinically trained, but the trust that you have with your teams and physicians too, right? And our MAs and our nurses, what you don't know is so much more important, because then you know where to ask for help, right? Or maybe you have a plan, but let me bring this other person in to help support what my plan is. It's such an important piece of what I've taken throughout my whole career. And I think that's what's helped shape how I make decisions clinically, strategically, leadership, operationally, because I know there's things I don't know. How do I step back and say, who do I need now in my corner to help me do this?
Yeah, it's a great response. And I think that comment about, it's so important to know what you don't know, much more important than knowing what you do know, right? To me, that certainly applies across the board. To me, in a legal practice, that's so important. I have to I think a lot of successful lawyers I've seen are great at asking questions. It's really hard to know every answer. I know, Aubrey, many times you thought I was probably the source of every answer, but I'm not. That's questions. I mean, it's so important
Right.
it's so important to recognize that just across the board, regardless of your area of expertise. But yeah, that's really important. Excellent. So when I kind of want to shift gears a little bit to, you talked a little bit about sort of being on the front end of value-based care, managing risk, and scaling some of that in a very complex organization. And when organizations scale, I'd be interested in your thoughts on this. I found that legal issues don't necessarily show up in one
Right.
big dramatic failure, right? That it's
Right.
a series of small inconsistencies. Those
Yeah.
inconsistencies tend to multiply very quietly.
Hmm.
So someone
Yep. Yep.
internally or hopefully not, but from a government agency notices them before leadership does.
Right.
And that's usually not the way anyone wants to learn about their internal processes. I often joke with healthcare leaders that they're rewarded for speed, compliance, legal. They're rewarded for asking, "Are we sure about that?" And there's that, and I've talked about this with other guests. There's that natural tension between those two areas where there's a lot of risk, but there's
Yep.
also a lot of opportunities for growth. You've worked with organizations that they scale quickly, new service lines, new markets, new providers, and perhaps only realizing later that um, governance is missing, documentation is missing, or compliance perhaps hasn't kept pace. I've been part of a number of
Hmm.
clients that have experienced this, and nothing nefarious, nothing. It's just as
Right.
a nature of growth. And
Right.
you, having overseen large multi-specialty provider groups and enterprise healthcare operations, in your experience, what breaks first, or what's the first thing that comes to mind when organizations scale too fast?
I don't know about if I have an answer for first, but it is what you said. You start to see the cracks. And I think the safety with your teams where they feel safe to speak up is where you can stop that big scale from happening, right? So you've the boots on the ground teams that are in it who start to say, "Hey, I saw this," or "Hey, I saw that." The safety that they have that you foster for them as your team to bring that up to you when they first see it or they first hear it or they first think it stops stops the crack from becoming, a volcano. But I think it's really the small things that start to break first, just like you said. Somebody maybe you have a patient complaint, which you think, "Gosh, that's odd. I wonder why that happened." And then you want to make sure if you don't address that, that large scale quality or safety risk really will happen, right? So I think it's a I guess it's a hard question to say first because I think what you wind up seeing first is that quality and safety issue, right? It's that comes
Mhm.
to the forefront and on what breaks. And I think in order to stop that as you're scaling is to continue to pause and say, "Oh, how is it going? What do we need to do? Where do we need to pivot?" And again, that safety with your teams for them to be able to say, "Hey, here's what I saw. Hey, here's what I saw," and not be afraid to be penalized because something went wrong. Things are going to go wrong all the time. I mean, nothing's perfect. I mean, in any organization. So I think, as you scale to continue to pause and say, where do we need to go next? Who do we need to pull in? What do we need to do that's maybe not working over here in this, in this service line versus this service line? Again, whether it's lab, dental, clinical, operational, what have you. I think when you don't have that safety is when the things crumble fast because then you get the, well, I didn't know, right? Well, how come no one told me?
Right.
So I don't know that I answered your question.
No, no,
I
absolutely.
did.
So, and I'm with you. So, I like how you brought up patient safety because I've never met a clinical leader, um, or a healthcare a leader of any healthcare organization that didn't put patient safety first, that wasn't at the
Mhm.
forefront of their objectives, goals. Yeah, yeah. There's a lot of other stuff that's really important. Number one, it's clinical safety for a lot of good reasons. And so then the question is, so then yeah, I mean you want to scale, you want to grow very fast, but not at the expense of patient safety.
Right.
So how do you do that? And I think you did answer that question. It's to me it's having that a prescribed procedure process in place
Hmm.
to intake patient issues, quality issues. How do
Hmm.
you handle that? How do you protect that from a legal standpoint?
Hmm.
And how do you see those to resolution and get better and
Hmm.
things like that? Having that infrastructure in place, and balance that with growth is
Yeah, I think those huddles are so important with the teams, like a leadership huddle, but then also the huddle for the boots on the ground teams, right before you start patient care. What are we doing today? What's everybody's role? Where are we going? Any concerns from the day before? I think especially as you scale, that is so important because then you've got a tight knit group who every day are meeting and saying, okay, what are we doing? How are we doing it? How do we do better today? What are we looking for? What are we looking out for? Where could things maybe go wrong? And again, this applies everywhere, right? It applies in the hospital, it applies in a clinic, it applies for your team, for my teams that some may not be clinical. That space to say, who do we need to bring in? Where do we need help? Again, what team members need to be brought in, whether it be compliance, legal, a safety person, an educator, to help fill those gaps. But yeah, I don't know. I think that's the best way.
Totally agree. Now, sort of stemming out of that, what one way to promote quality and patient safety is through provider incentives, and this is a topic I've talked to a number of folks about, even on this podcast. How do you
It's a hot topic.
incentivize providers, right?
Right.
And what is it that promotes the behavior that you want to see in the clinical environment?
Right.
And frankly, I've helped a lot of clients develop these provider incentive programs. It's an area where I spend a
Yeah.
lot of time advising because incentive models sit right at the intersection of quality reimbursement
Mhm.
and legal exposure. On paper,
Yeah.
incentives are about driving better outcomes. And in reality, poorly designed incentives can create documentation issues, it can create audit risk, or even behaviors that no one intended.
Right.
So
Right.
it it's and you mentioned being at the forefront of developing some of these programs, and
Mhm.
I'm sure you would agree with this, that being involved early, asking
Oh yes.
asking uncomfortable questions before the
Yep.
program launches,
Oh yeah.
before we have
Oh
to say it
yes.
to others.
Right.
It's so important. What are the hardest parts, or what is I always the hardest. It's
Yeah.
what's the first thing that comes to mind when
Yeah.
when aligning incentives with real patient outcomes? What's the hardest part of that?
Yeah. Yeah, so I think, again, back to what you said, our as providers, we all want to provide the best care, right? I mean, there's no two ways around it. That's why you go into healthcare is to help people, right? So how do you drive those outcomes to make sure that we're doing it every time? We're making sure every patient's blood pressure is where we want it to be, or we're moving towards that, or that every patient that needs a mammogram is getting a mammogram. So antibiotic stewardship's a big topic right now. How do we make sure that's at the forefront? And I think there's it's multifactorial, right? Just as everything is. But one is what is the patient population and provider population that you're looking at right now, right? Are we looking at urgent care incentives or are we looking at primary care incentives or are we looking at I don't know, a cardiology incentive, right? It might be different. It's going to be different, right? Where can are we able to get the data because, these EMR systems have so much data. So can we get the data to drive the outcome that we want, right? So can we get the accurate blood pressures for the patients and then the data to support that the blood pressures have improved over a month or two? But in that, do we have the data on who's the owner of making sure that blood pressure
Mm,
is in range, right? So
right.
who owns that patient? And I use the quotes because owns I use that term lightly, but
Yeah.
whose responsibility is it, right? Is it the primary care providers? Is it the urgent care providers? Is it the cardiologists? Is it everybody's?
Who's going to be accountable at the end of the
Who's
day
the
for that?
accountable party?
Yeah.
And then can you receive that data and process it in a timely manner where when you're launching the incentive, you're not looking at something a year retroactive, right? Like you want to be as in real time as you can so that you actually are affecting change, right? And then you have to look at contracts, right? And that's where a lot of times you come in. You have to look at and compliance too, right? What are we making sure that we're being fair? Are we when we put these incentives in place, is the percent, however we're doing this, is it are we looking at fair market value? Are we looking at in totality that these providers are actually seeing a pool of patients that would even affect change to begin with? Is the percent, your denominator high enough to be able to even get accurate data, right? So I think it's easy to sit in a room and say, "Hey, we all need to make sure everybody gets a mammogram," right? But without all of those other players in the room and without again us stepping back to say who else needs to be at the table to make sure these are s- standardized and well vetted. You're not going to be able to launch a plan. It's it's not going to work. Again, back to the accountability. So
Yeah.
anyhow, I don't think people realize all the things that go into all the nuances of something like an incentivized plan. They're great, but again, you need to have everyone at the table to make sure that we're doing what's fair for everyone, for the for the patient, for the provider, for the everybody.
Right. I mean, you explain a lot of the challenge. It's tricky. That's
It's
really
tricky.
hard, especially in a multi-specialty
Yes.
practice.
Mhm. Right.
That you're managing care for a
Mhm.
target patient population. As you mentioned, primary care, you got cardio, you got a number of different service lines, specialty areas, and it's really tricky. You mentioned data. That's a huge one for me because I've seen um incentive plans designed where later was found out there's just no way to get accurate data.
Me too.
Uh,
Yeah.
it-
With
which
all, and you could have all the good intentions, right? I mean,
oh
you're
yeah.
trying to it's the it's not the intention, it's the right, you can't get the data. Yep.
Yeah,
Mhm.
ensuring you have the ability to get accurate data for that
Mhm.
metric is so important. And the other thought that came to my mind, Aubrey, as you were talking, is the way to ensure that these quality metrics don't become sort of this check the box exercise.
Right.
I asked, so the first episode I actually interviewed my brother, and I asked him, he was a physician in Utah, and he's involved in medical education now. And I asked him this question about, how do you change the behavior in primary care, and how's the reimbursement overlay with that? And he just said, like, I don't think a lot of primary care practitioners really care much about it, only because if you have to fill out, form XJ 2000 and this and check these boxes, for a little kicker at the end of the year, it's just, I mean, some will, but not
Mhm.
vast majority. So the how do you avoid this check in the box exercise? Is it identifying metrics that truly that apply to that particular
Mhm.
practitioner? Because you're right. I mean, I've heard this before from practitioners that, hey, I'm responsible for ensuring that everyone gets mammograms or everyone
Mhm.
gets some sort of screening, but no, I don't see these patients, and I have no control over this metric. Is that how
Right.
you avoid this check in the box sort of mentality?
Yeah, I think it comes down to being intentional on why are we doing this and what is the outcome we're trying to drive. So again, let's take blood pressure, right? If you're checking a blood pressure in any type of clinic and it's high, you really want that blood pressure followed up, right? Whether you repeat it in the clinic or you say, "Hey, I need you to go to the primary care." So it's driving a behavior for every clinician that's doing that metric, right? So if you get your blood pressure checked in the orthopedics office and it's high, that doctor should say, obviously an orthopedic doctor doesn't do anything with blood pressure, meaning they're not going to give you medicine for it, but they know when it's high, then it's their responsibility to say, "Hey, I noticed it's high today. You should go back and see your primary care doctor," and maybe send the primary care doctor a message to say, "Hey, I saw Mrs. Smith in the clinic. Her blood pressure is high. I'm sending her to you." Right? So it's carrying that muscle memory of why do we do what we do, and when we do it, what are we going to do with that information so that we're driving the change we need to drive, right? um and I think that's ultimately what we need to get to. It's not just ordering the mammogram, it's explaining to the patient, why is this mammogram important and why should you go schedule it, and then the metric should be potentially fulfillment of the mammogram. And then if it's not fulfilled, having somebody track down why wasn't it fulfilled. Maybe they don't have transportation. Okay, well then maybe we bring the mammogram to them. So I think it's really important that it isn't a check the box, because we're not helping anyone by just checking the box, right? Just saying, "Hey, yeah, I ordered a mammogram. It's out of my hands now," right? So
Yeah,
anyway,
no, the fall. Yeah, because then it's not checking the box; it's actually managing care, right?
right.
For
Yep.
improved quality outcomes.
Yep.
Yeah, that fantastic. You're a trained physician assistant, advanced practice provider, and APP utilization is one of the most common areas where I see well-intentioned organizations get tripped up legally. I I mean, for a
Yep.
variety of reasons. Scope
Yep.
of practice laws, vary from state
Oh yeah.
rules.
Yep.
Supervision requirements can really
hmm
widely vary by state and change over
Yep.
time and don't always align neatly with operational needs. Unfortunately, there's no, this is how we've always done it, legal defense. There's no, I
No,
often tell people, there's
there
no
isn't.
everyone else is doing it safe harbor. That just doesn't fit. I've never heard it. I mean, if maybe someone out there has heard it, I would love to have that. No, but I don't think it does. The state scope of practice laws are a great reminder that healthcare compliance does not believe in national uniformity. I mean, there are certain compliance issues, certainly very important compliance issues that are governed and dictated at a federal level, but a large number of these issues are at the state level, which if you have a multi-state practice can get very, very complex. And you've
Mhm.
overseen delegation protocols and prescriptive authority for hundreds of APPs. What mistakes do you think organizations make when expanding APP rules?
Yeah, so it is so complex, John. Every state is different, and not only is every state different, but PA rules and NP rules are different, and
Right,
NP
right.
certifications are different, right? So you could have, you know, one state where everything's the same and these are their rules for supervision. And then you've got a state where it's completely different and there's so much more independence for, let's say, nurse practitioners than there are for physician assistants. And how do you reconcile that with what you're trying to scale, right? So I think as these companies try to scale into other states, the very first thing questions that need to be asked is to bring the compliance department in and say, okay, let's take a look at what our processes are right now for the state we're in, right? Or whatever, however we're running it from the state we're in. What do we need to modify, adapt, or adopt to the state we're going to? And where are those intricacies and where are the differences? Because it can be as far as, there's a supervising physician can oversee 10 APPs, and you could have a state where no more than 4. So it gets very complex. You can have a state that they have to have on-site meetings every month,
Hmm.
which then takes away being able to use maybe a supervising physician who's remotely supervising versus never having to do anything like that. So I think making sure that you've got a good team that's working on that before you even think to start hiring APPs, or if your business model is highly APPs, making sure that that is the one of the first things you look at, because you have to adhere to all of those regulations in order for them to be able to practice, right? And they're and those APPs are looking to the business to make sure that all of those operational processes are up to par, right? I mean, we still want to make sure that we are in compliance and the business is in compliance. And so I think when we were setting these up for all of our states, we had probably more than monthly, but what I can remember right now is monthly calls with compliance with grids on who can do what, where, how can we make this work? What is the ratio? Because when you set up a clinic, we all know that there's a giant physician shortage and it's getting worse. So, APPs are coming to the forefront for many reasons, for staffing and patient needs. And so how can we meet our patient needs but also be in compliance with that state? So it's something that has to be figured out before you even think to put a brick and mortar somewhere. If your frontline clinicians are APPs, because it varies widely, and some are very much more prescript, and then some you read and you're like, wow, that's very vague, and how do I interpret that? And that's where you come in. That's where we need a lawyer
Well,
to say, what are they really saying?
yeah. Well, you brought up a lot of great points, Aubrey. And is that really the way to kind of manage that risk? Is you have to get really granular. Because so to me, I view this as differently than some of the other sort of compliance or procedural issues
hmm
that you deal with in multi-state practices. There are some
Yeah.
things like, I don't know, insurance related things or
hmm
reimbursement related things where, I've seen some organizations say, we are going to take the most conservative, most restrictive rule out there and that state's rule and apply it across the board. Well, that's
Mhm.
probably not that easy to do for
Right.
all the reasons you
No, it's
described.
not.
One being,
Right.
even in the own state, in one state, you have different rules for NPs and PAs, and they
Right.
vary so widely from in person
Mhm.
to like, what the heck is this?
Yep.
Is the rule sort of vague, vague language in this other one, and you don't know exactly what to
Right.
apply. It's not that easy. So is that
Mhm.
the best way to manage risk? Is really
It's
you've
not.
got to have the support infrastructure, get granular on understanding those rules,
Mhm.
and be able to implement and audit, your performance of complying with those rules.
Right. We've done it both ways. We've done it where we took the most restrictive state and said, "Okay, we're just gonna go with this
Mhm.
because it's easier to copy paste." But what you run into is as you start to scale and you have states where you need more APPs, but maybe you don't have that supervising physician support, or you're limiting the number of APPs that could be supported by a supervising physician because you're using another state's laws that are restrictive. Well, what do you do then? Then you almost have to change everything you're doing, right? So I think you look at it in totality and say, what is going to work best for the business while staying in compliance for that state, right? I don't think a copy paste works because I've seen it. I've s- It'll work for a little while, but again, as the business grows and the needs, you really do need to be able to say, okay, oh gosh, well here actually we have so much more leeway. Let's use that so we can increase scope and increase practice while staying in compliance in that state, right? And maybe that's how it drives your business model, right? Maybe that's where you say, okay, I'm going to open more clinics in this state as opposed to that state because we can utilize our APPs to a higher scope. We can, you know, they have more independent practice authority. I mean, I think it is moving more that way. You are seeing a shift in, there's a compact now for APPs and to be able to get licensure across multiple states that's moving forward. You're seeing more independent practice states for nurse practitioners. I think there is a shift, which is great because we just have this gigantic need for patients and not enough. We just don't have enough providers. I mean, there's just not enough. So,
Yeah,
mhm.
excellent points. Sort of the your ability to operationalize compliance with rules, sort of driving the growth plan, right? In
Mhm.
what states you go to. That's I've seen that a number of times. That's very important. Absolutely. It's
I mean,
great.
yeah,
Excellent.
maybe how you have to do it.
Yeah.
Mhm. Yeah.
Aubrey, I'd like to jump a little bit and sort of touch on something you mentioned earlier. Your experience working on the front lines during COVID, and some of the leadership lessons that you learned from that experience. And COVID obviously forced leaders to make decisions faster than most policies were written for. And from my side of the table, it created some very interesting documentation challenges. That yeah, I used to teach an undergraduate healthcare law and ethics class, and I would often get comments about sort of complaining about what hospitals were doing and not doing, and it was changing from day to day. And I thought, well,
Mhm.
yeah, they're acting based on the information they have at the time.
Right, you're getting
It was
rapid fire.
always changing. And so,
Right.
and so those documentation challenges got really difficult. And
Mhm.
the real challenge is making fast decisions and leaving a
Mhm.
trail that explains why those decisions made sense at that time. I'm sure you experienced, and you
Oh,
played
yeah.
a leadership role during that time.
Mhm.
What lessons? I mean, just give me a couple bullet points. What lessons
Sure.
did you learn from that experience that still apply, that maybe you call upon today?
Yeah, so I think, going back to those huddles, I mean, we had a morning huddle, I mean, early morning huddle where we had an infectious disease specialist who was up on everything, who was again reading things minute to minute to minute, trying to make sure that we were adhering to the most recent guidelines. And then we also had, individual team huddles and clinic huddles with very rapid information dissemination. So I remember we also would get an email every morning about here's all the updates and everything that's going on right now. And then we would get an afternoon email with here's all the updates with everything going on right now, and it would be things from what patients can and cannot be swabbed, what patients can and cannot be hospitalized or should be, what does the quarantine look like, what is the PPE situation. But it actually was comforting to have that communication because you knew you were always you were doing the right thing with the information you had at the time, right? And I think that, again, it was, you were huddling 3 times a day sometimes because things were changing so rapidly. But I think that's where now it is so important to have those connections with your teams and to have those daily or weekly meetings where you're really constantly in contact with your team, because things still change quickly. I mean, not as quickly, but even, we've had MMR outbreaks, we've had monkeypox outbreaks, and we've still had to pivot quickly, right? From all and it's more ingrained in us now to say, okay, this is information we have at the time. This is what we're going to utilize. It's documented. And then moving, the next day, this is what we're going to utilize. This is how we're going to do this. And I think you take that information and you have you have the teams. You've got the infectious disease, back to COVID, infectious disease team. We had compliance, we had legal, we had our pulmonologists, we had, our nursing staff, operations, everybody kind of working together, each having their own little niche, but everybody always coming back to say, okay, what is the information at the time and how are we going to operationalize it right now with what we have? And so I think now that at least we're out of that, that's similarly how effective healthcare leads, right? We have these intentional meetings with the teams, with people who come from all those different facets to make sure that we're doing the right thing with the information we have at the time. And I think sometimes we get caught up in, oh my gosh, I've heard, do we have to have compliance again, or do we have to pull legal in again? And to me, it's always been the joke. And you may remember this, that I always had compliance on one shoulder and legal on the other shoulder, because I would rather have you there in the beginning so that I know where to go.
Sure.
And if I'm going the right direction, right? And so I think that's so important in these bigger teams and with these huge hospital systems. We've got everybody at the table so that we're all marching together.
Yeah. That's why we always got along so well, Aubrey, I think.
Yeah.
Literally sitting on your shoulder. So it's
Exactly.
literal. So 2 takeaways that I have from what you just said, which were excellent points. Documentation of why the change is being made, the information that you're acting on at that time that serves as the basis for the change, and this multidisciplinary communication on a regular, frequent basis.
Right.
All very important that I'm sure apply then, apply now.
Throughout. Right. Yeah.
So Aubrey, I'm gonna leave you on this topic.
Okay.
I tend to meet leaders and boards, and after something has gone wrong, it's gone sideways. So I have a deep appreciation for questions that weren't asked early enough, and I'm sure you've seen that throughout your career. And this is a scenario in which I think legal, clinical, operational leadership really have to come together. Boards don't necessarily get into trouble because they ask too many questions. It's usually because they didn't know which questions to ask. And as much as this hurts my feelings, no one really ever calls their lawyer to say, everything's perfect, just want to chat. And I don't get those calls. I don't,
No, we probably don't.
I'm far enough in my career, I don't take it personally anymore, but that's okay. It's okay.
Yeah.
Now, if you could give one piece of advice to healthcare executives, Aubrey, about managing compliance risk, maybe not even compliance, like how do you just manage general risk? Well, what would that be?
Honestly, I would say pull the team in early, right? The moment you have an idea of, hey, I want to go this way with the business, pull in someone from compliance, pull in someone from legal, pull them in immediately, because it's so much better to have those teams at the table just to listen to where you're going. Again, I think unfortunately, and I know you've felt this before, people say, oh, I don't want them in the room because they're going to stop me from doing what I want to do. Well, I have the opposite. Like, I want you to tell me where my gap is. I want you to tell me why we can't go this way. But most of the time, it has never been, in my experience, when you pull teams in early, it's not a no, we can't. It's a, hey, did you think about this? And maybe we go this way instead of that way. Or maybe we'll still go that way, but how about we do it just a little bit differently, because we have to make sure that this is thought of, or this is pulled in, right? I think people have to stop thinking of other compliance and legal and risk and quality and safety as scary. They're going to tell me I can't do what I want to do. And instead say, hey, tell me what I can do. Like, here's my idea. I want you here right now so that you can help me make this happen. Right. So.
Yeah. Well, let me flip that around a little bit. So if you were to say, okay, here's a brand new lawyer, John Rhodes, or a compliance professional, and if you could give me a piece of advice, or someone out there who's in the legal and compliance areas, what advice would you give them from your perspective as a healthcare leader on the business side, on the clinical side,
Yeah.
to us, how can we develop that? Because I love what you said. How do we help foster that? How do we help develop that relationship and that trust to be able to get to that point?
Yeah, I think the best teams that I've worked with have said, "Well, tell me more. Tell me why." They don't come in with a, "Oh my gosh, you can't do that," or, "Oh my gosh, this is gonna open us up to so much." it's not it does there's no negative. It's just a, "Okay, tell me more." And I think that's how that relationship is fostered, right? And I think that's with all teams. I mean, operations, but I think early on when you're meeting the new leaders in the maybe you're a new lawyer coming in and you're meeting this operational person or you're meeting a clinical person and they're giving you the ideas instead of saying, "Oh my gosh," like, maybe you do have bells and whistles going off in your head, but
Sure.
instead of instantly going, "What's going to happen?" It's, "Tell me more. Tell me why, tell me more, and let me see what we can do with it." Right? I think I think that just it fosters that partnership as opposed to feeling like, "Oh, I can't."
That's been my experience as well. Just and I've talked about this before. Having
Really good at it. You'd be
well,
like, "Okay, Aubrey, what's your idea?"
I wasn't fishing for
Tell me your
compliments, but I appreciate
idea.
it. Having that calm demeanor, regardless of how terrible the situation may be, um, and really, there are very few things that I've heard that are absolute no's. Like, no way can that happen in the way that you propose it. Now, we may have to change some things to get where you want to go.
Right.
And we have to structure it a little bit differently, but and then from there it becomes an issue
Mhm.
of risk tolerance. What are
Mhm.
low risk, medium risk, high risk proposals? But you're right. It's sort of the strategic partnership, working together and collaborating to find a way to meet those objectives.
Well,
Yeah,
and where does it fall? Like, whatever the project or idea or process, where does it fall in is this something we have to do and we need to figure it out, right? Or is this something that is malleable and we can, okay, let's noodle on it a little bit and, see where we go with it. I think prioritizing too and making sure it aligns with the strategy is important. Again, that's why you have everybody there at the table early to say, where are we going?
I love it.
Anyway,
I love it.
thanks,
Well,
John. This has been
Aubrey,
fun.
this was awesome. One thing I really took away from this conversation, things that I learned, most compliance risk doesn't come from bad actors, right? It comes from good teams moving
Yep.
fast without alignment.
Yep.
Leadership, operations, clinical teams aren't pulling in the same direction. The cracks can show
Mhm.
up quickly. I learned a lot. I really appreciate it, Aubrey.
Thanks,
I
John.
appreciate your time. And that's it for this episode of Health Law Pulse, where our main goal is to just not put you to sleep. And Aubrey, I think because of you, we've achieved that today. So I appreciate that. Thank you for tuning in. If you enjoyed today's episode, subscribe, leave a review, and share with a friend. We are on YouTube, Spotify, Apple Podcasts, and you can also find links to these episodes on my website at www.healthlawcouncil.com. We'll be back soon with more conversations at the intersection of healthcare, law, technology, and leadership. Thank you very much.
Thank you.
Thank you for joining us today on the Health Law Pulse. This podcast has been brought to you by Health Law Council LLC, a healthcare law firm you can rely on. For more information about the services offered by Health Law Council LLC, visit www.healthlawcouncil.com, or you can email me at john@healthlawcouncil.com.